What are biomarkers for cervical cancer immunotherapy? Imagine a way to tell which patients might respond best to immune-based treatments for cervical cancer. That's where biomarkers come into play. These are measurable biological indicators that help doctors predict how well a patient might benefit from immunotherapy. In cervical cancer, especially when it becomes advanced or recurrent, immunotherapy offers new hope. But not everyone responds the same way, so identifying the right candidates is crucial. One of the most important biomarkers is PD-L1, or programmed death ligand 1. This protein is found on tumor cells and immune cells within the tumor environment. When PD-L1 binds to PD-1 receptors on T cells, it suppresses the immune response, allowing the cancer to evade attack. High levels of PD-L1 are seen in many cervical cancers, especially squamous cell types, with some studies reporting up to 80 to 95% of cases showing expression. Clinically, PD-L1 expression is measured using scoring systems like the Combined Positive Score or Tumor Proportion Score, which quantify how much PD-L1 is present on tumor and immune cells. Higher scores often correlate with better responses to immune checkpoint inhibitors such as pembrolizumab, which target the PD-1/PD-L1 pathway. Another key biomarker is tumor mutational burden, or TMB. This measures how many mutations are present in the tumor's DNA. Tumors with a high TMB tend to produce more neoantigens, which are new proteins that the immune system can recognize as foreign. This makes the tumor more visible to immune cells and potentially more responsive to immunotherapy. While cervical cancer generally has a lower TMB compared to cancers like melanoma or lung cancer, some patients with higher TMB may respond better to immune checkpoint inhibitors. The Food and Drug Administration has approved high TMB, defined as 10 or more mutations per megabase, as a biomarker for immunotherapy across different cancers, including cervical cancer. Microsatellite instability and mismatch repair deficiency are other important factors. These genetic features lead to hypermutability, increasing the number of neoantigens and possibly making tumors more susceptible to immune attack. Although these features are less common in cervical cancer compared to other cancers, tumors with high microsatellite instability or mismatch repair deficiency may respond well to immune checkpoint inhibitors. Blood-based markers also provide valuable insights. Ratios like the neutrophil-to-lymphocyte ratio or platelet-to-lymphocyte ratio reflected systemic inflammation and immune status. For example, a lower neutrophil-to-lymphocyte ratio has been associated with longer survival in patients receiving immunotherapy. These markers are easy to measure from blood tests and can offer additional prognostic information, although they are not yet standard for guiding treatment decisions. Research continues into emerging biomarkers, including microRNAs, tumor-infiltrating lymphocytes, and new molecular targets like diacylglycerol kinase enzymes. These areas hold promise for improving how we select patients for immunotherapy in the future, but they are still under investigation and not part of routine clinical practice. In summary, the most widely used and validated biomarker for cervical cancer immunotherapy is PD-L1 expression, assessed through scoring systems like CPS or TPS. Tumor mutational burden and microsatellite instability are also important, especially in select cases. Blood-based inflammatory markers can add context but are not definitive. Combining these biomarkers helps doctors personalize treatment, aiming to improve outcomes and reduce unnecessary side effects. Always remember, medical decisions should be made in consultation with healthcare professionals who can interpret these tests within the full context of each patient's health. Ongoing research continues to refine these tools, bringing us closer to more effective, personalized treatments for cervical cancer.